Now, we all know, however, that docetaxel patients have a modest survival benefit and they will progress. They will progress by, again, a rise in PSA. They will progress radiographically. They will progress symptomatically. So now we get into the next phase, and again, if we go back to our prostate cancer disease continuum chart, basically, at this point, we get into the post-chemotherapeutic patients. And again, we're moving down the road. We're getting sicker, more symptomatic patients. So what is approved in the basically post-chemotherapeutic, post-docetaxel patient? What's currently approved by the FDA in this space?
I want to say, Raoul, it was late 2011 that a drug called cabazitaxel, or Jevtana, was approved for docetaxel failure, second-line chemotherapy for prostate cancer. Again, it showed some modest benefit in survival. I think it was 2.4 to 2.8 months improvement in survival, which helped it get its FDA approval. Again, I don't think urologists are all that comfortable in administering or giving it. They've usually formed alliances with oncologists to help them in this regards. And pretty much the data has shown that there's a little bit higher incidence of neutropenic sepsis and grade 3 to 4 toxicities with this product, higher incidence of hospitalizations and things like that. But again, it's exciting that we do have something that even works after docetaxel fails.
Do you currently have a medical oncologist at Urology San Antonio that's either part of your group as a partner, or you have a nice working relationship that sees patients in your office?
We have a unique situation in San Antonio. Of course, we have a radiation center, and in that radiation center, we have built 4 chemo bays. And that area has been leased out by an oncologist that we work with very closely, whether it be with kidney cancer, bladder cancer, or prostate cancer. We do clinical trials with this individual. We're doing a couple of docetaxel trials with him right now. And then, of course, when people fail first-line chemotherapy, he's the one who assumes their care when we're giving Jevtana or cabazitaxel.
Brian, do you have any experience with Jevtana, or do you pretty much agree with Dan's comments that this right now is mostly, with some rare exceptions, really still in the hands of our medical oncology colleagues?
Yeah, we don't have that kind of relationship with an oncologist and don't do chemotherapy infusions in our office at all. But I think, relative toxicities, and it's for the symptomatic patient. This tends to get pushed back down the disease continuum. And in some cases, even the oncologists are fairly loath to initiate taxotere chemotherapy, I think.
No, I think that's sort of the nice thing about this, and I keep having to use this word, this space that we're currently living in, is that if you think about it, we've had more drugs approved over the past 2 years than we've had approved in the past 2 decades. So we're seeing this explosion of oncolytic therapies. But clearly, when patients failed docetaxel, the first one out of the chute was Jevtana. But then now, there's been now some oral agents, which obviously, once again, plays very nicely in my way of thinking for the urologist to continue to be involved with patient care during this advanced stage. So there was Jevtana, and then in April of 2011, abiraterone or Zytiga got approved. So tell us a little bit about what you know about abiraterone or Zytiga.
I want to say, Raoul, in late 2011, the 302 study for abiraterone/Zytiga was approved. The study was designed where patients were randomized to either abiraterone plus prednisone or prednisone alone. There was a greater than 4-month survival advantage. The mechanism of action of this drug is that it inhibits it's adrenal or a biosynthesis steroid androgen biosynthesis inhibitor. Okay, so it works by blocking CYP17 in the adrenal pathway. It's got a unique mechanism of action that we have not used before, other than similar to ketoconazole, but it's a lot more specific. Because you block the production of testosterone, you have some excess mineralocorticoid problems post that, and so you do need to give it with prednisone to prevent some of these issues in the future.
So the prednisone is given to mitigate the side effect profile due to the mechanism of action of the drug, not because of an anti-tumor effect,
That's
which
correct.
obviously a lot of us historically have used in the past. No, and so I think that's right. I think this is, obviously became available. And again, once again, the beauty, like you mentioned, is the fact that it's an oral agent. And I think the side effect profile is very tolerable. It doesn't require an IV. It doesn't require an infusion center. So.